Hi everyone, Michelle Lyons back with you again. I continually say it, but I'm blessed to have so many learned colleagues and friends in all sorts of different worlds, but particularly in the world of physio. And a couple of weeks ago, I decided just to kind of step outside my comfort zone a little bit, and I went to a foot and ankle course. And one of the teachers on the course was my lovely guest today, Sheenagh Sexton. And I really gained an insight into possibly some of the missing links that we as women's health physios and women's healthcare professionals might sometimes miss. Now, we know as we get older, estrogen levels change, and we know as well that estrogen, as I'm fond of saying, has about 400 different functions in the female body, but it definitely affects connective tissue and ligaments and tendons. And I was really interested in what Sheenagh was talking about at this weekend, so I thought I would take this opportunity to invite her on and exploit her knowledge. Sheenagh, thanks a million for coming on. Would you like to just introduce yourself, where you're from and what you do?
No problem. I work in private practice in Dublin, and I work in a clinic, and we specialise in foot and ankle problems. So as well as the normal musculoskeletal caseload, we see a lot of foot and ankle problems, and a lot of these are complex and are chronic, and because of that they're rarely just a problem with the foot. So we are always looking up the chain. So we're looking to the knee, to the hip, always looking to the pelvis, and sometimes we venture beyond. We try and push ourselves beyond. So we're looking to see why this foot problem has happened, why it hasn't got better, and trying to put together a problem list to find out all those functions that are affecting the foot. So that is what I do. I try to look at the whole body, as all physios do. We're great at looking at the whole person. So I do a lot of fascial release. I do acupuncture as well, and I also do a lot of Pilates. So trying to get the core function good as well.
Brilliant. Because, you know, nothing happens in isolation in the body. And I suppose most people go to see a physio, I would imagine, particularly a foot and ankle specialist, because of pain. Do you find that you see an upsurge of kind of middle-aged and beyond patients, or is this a young person's issue, or are you seeing all sorts of age groups?
We probably see predominantly females, because I think they're good, first of all, at referring themselves and getting help, but also because they're developing these problems. We probably see mostly middle-aged and beyond, but we get a nice splash of kids and teenagers coming in with all sorts of problems as well. So a good range.
Do you think it's predominantly women because we're good at taking care of ourselves, or because we make bad footwear choices?
I don't think the footwear choices are that bad. I think mostly people come in.
Have you been talking to Jenny Burrell? Have you?
No.
This is our ongoing discussion. Jenny wears lady shoes quite a bit, and we have an ongoing discussion because my motto is give me comfortable shoes or give me death. So I'm suspicious that she's gotten to you already.
The main problem we see with shoes coming in is we get people to come in. Sometimes they'll come in the first day with their bag of shoes. If not, the next day they come home and say, bring a bag of your shoes in. Probably the biggest thing is that the shoes are maybe too worn. So people are wearing shoes for years and years and they like them, but actually they're worn and they've lost their support and they've lost their shock absorbing. So we would go through the shoes and say, that's a great pair. I like the height of the heel. That's a lovely firm heel counter. I'd say yes to that one. They're totally worn. I can put my finger through the sole there for the bin. Those boots are nice, but we need a little lift and we need an insole, and that is quite low profile. So shoes are definitely a big thing. Absolutely. So we're looking at the position, the function of the foot. It's not just the muscles and the tendons. We're looking at how the foot is sitting. Do they need an orthotic? And then advice on a good shoe to hold everything together.
So one of the things that you talked about at the course in Athlone a couple of weeks ago was how we acquire flat foot problems as we get a little bit older. I wonder if you could just kind of give us an insight into your perspective on that.
So that was specifically talking about acquired adult flat foot, which really is relating to a problem with the tibialis posterior tendon. So when you have someone with a really low profile arch that is walking around all their life with this very low arch and the heel functioning in valgus.
Pretty flat.
Pretty flat, absolutely, something like that. So when you look from behind and you see the heels squinting out to the side in valgus, and you see all the toes sticking out to the side, and you look and you see no arch there, their tib post tendon, which is wrapped underneath the medial malleolus and then attaches underneath the foot, that's on a constant stretch. So all day, every day, that's functioning in a stretch position. And it simply can't function well like that. And it's the primary dynamic stabilizer of our medial arch. So what happens over time is that tendon becomes frayed and eventually can rupture. So if you see someone coming in initially and they've got pain behind the ankle, swelling, very low arch in the foot, they're starting to head in that direction. Now, if they're not caught early and controlled and stretched out, their tight structures, they will go on to form an acquired adult flat foot. So the navicular just drops and the arch just collapses, and they're pushing off and weight bearing all along that medial side. And then in time that goes on to become a fixed problem. So it's uncorrectable, and then they're really hard to treat. So they're the type of people that if they come into you, they really do need orthotic correction. So if you're not in a position to do that, you should refer them to one of your colleagues who do, because they need the big orthotics, the deep heel seat, high medial flange, skive, the works. They need a really good shoe. They need their Aquinas stretched out. And Aquinas is probably something we should talk about, because we're talking about women and footwear and heels, and a lot of people are doing walking and they're couch to 5K and their muscles are getting nice and strong, but they're tightening up. And then with that tightness, then you get an Aquinas. So when you're walking, and then you're coming to, your body's coming over the foot and you're running out of length in the calf. So what the foot does is it overpronates to try and get an extra bit of dorsiflexion through the middle of the foot, through the mid-tarsal joint. So we're getting this overpronation just because we have a tight calf muscle. So that is a really, really huge thing that we have to deal with. So we spend a lot of time going through the correct position. So stretching the calf in a nice neutral position. And that probably brings us onto the windlass. So we're talking about lifting the toe and the arch, keeping that nice position in the back of the heel.
So lifting up the toe to really kind of tension along the arch here, would that be an accurate summary?
That's it. Yeah, now that doesn't, I suppose that skeleton isn't doing it very nicely, but what we're looking for with the windlass mechanism is the idea that the plantar fascia goes from the heel and it attaches distal to the MTP. So when your toes dorsiflex, that tensions the plantar fascia, and that helps to re-supinate the foot, pull the arch up, and give you a nice steady foot to push off. So the windlass mechanism is really important, because if we don't have that, we're going to push off an unstable foot. And then we get all those problems in the big toe. You get your hallux limitus, rigidus, bunions, shearing onto the second toe, all those things. So we would show people how to activate that windlass mechanism. And sometimes people come in as kids, and it's amazing to see a young child and they're overpronating and they lift the toe, they can't lift the arch. It just doesn't happen. So I had someone in today, a young boy, 13, I had to get it. He couldn't even do it standing. I got him sitting down in front of the mirror, and I got my hands down and I dorsiflexed the toe and I lifted the arch. I kept tapping and lifting, and eventually he got there. So we would teach that as an exercise. Okay. So if you assume someone can do it in standing, it's a really nice thing to do in front of the mirror. You get them to lift their big toes, and you get them to look at the arches and try and lift the arches, and then they can see how their knee position improves, their hip position improves. Get them to squeeze their glutes. That brings the legs into a really nice position. And then you can get them to activate their core muscles as well, and hold that and relax. And to do that as an exercise is a really nice positioning thing to do.
Right, so the emphasis is kind of two-pronged, that it's not just about getting into orthotics, it's actually strengthening the intrinsic muscles and then looking at the extrinsic relationships outside of the foot and the ankle as well.
That's it, absolutely. The orthotics is one tiny bit of the rehab. If you were to do that by itself, it would be unsuccessful. So the foot would not be able to tolerate it. So if you didn't address the Aquinas, you'd have this very tight leg and foot trying to operate on a rigid orthotic or on a high arched orthotic. It would be sore, it would be painful. They wouldn't comply, they wouldn't wear it. So we really are always addressing the tight structures, trying to strengthen up the core and strengthen up the foot, and then get them into the good shoes and the footwear, and then working from there. So we're looking at our problem list all the way up the chain.
Right. And, you know, kind of swinging back around to the acquired flat foot and problems with the posterior tibialis, you know, in terms of exercise strategies for that, are we looking at heel raises? I mean, what are your favorite ones for that?
Well, they usually do have some Aquinas, so you would be putting in a heel raise to start with, definitely. But then you're trying to load the tendon. We really need to strengthen the tendon. So let's say we've got the heel raise in, we've got a really nice orthotic in, so we're controlling the heel, we're taking the stress off the tendon. You might decide to do a little bit of taping, which is really nice along it, a bit of fascial release along the tendon, maybe a bit of acupuncture or laser, whatever you're working with. But in terms of strengthening them, we tend to start them sitting down. So in a sitting position, if you get a little tennis ball in behind the heels or behind the ankle bones, and you get them to rise up onto their toes, so they're going to lift the heels up, and at the same time you're trying to get them to bring the calcanei in towards each other. So with the tib post, we're looking for that inversion as we plantar flex. So they're doing a heel raise, but really the position has to be good. So there's no point in raising the heels and the heels staying out to the side. The heels have to come in. That's where the tennis ball comes in. So we do heel raises with them. Nice 2-second hold at the top, slowly lowering for 4 seconds. So getting that eccentric control. And then in time that can progress up into a standing position. And you can progress that further by getting them to rise up onto their toes on the 2 feet and then lift up the asymptomatic leg and then just lower down on that leg. And that's a little bit further along. So coming back to the sitting position, we tend to work with the intrinsic muscles, trying to build the core muscles of the feet. We're trying to get them spreading out the toes, trying to get the abductor hallucis, which is a really lovely stabilizer. And then probably my favorite exercise for the tib post in sitting is the windscreen wipers exercise, where the feet are down and you get them drawing their feet in towards each other. So pulling along the carpet or the floor and then pushing away from each other. And as those feet pull in, you can actually see, you'll be able to see the tendon and feel the tendon working. And it's not a hard one because there's no balance involved, there's no standing involved. So even your old lady with poor balance and sore feet can manage this exercise.
Fantastic. Those are really useful tips there as well. And what I've seen and what I've heard from both normal people, but also from physio friends, particularly who are in kind of, that 50s age zone, who are maybe they're noticing some changes going on metabolically and they're maybe embracing a new exercise strategy. Tendons, once we get into our 40s and 50s, tend to be a little bit less forgiving of change. But I think, we would never discourage anybody from actively exercising from a heart health and a bone health and a brain health perspective. But lots of women I notice report heel pain, or the dreaded plantar fasciitis at this life stage. Any advice or insights that you can give about that?
Yeah, it really is the dreaded thing, because when it comes, as it stays, it's long, and that's one of the first things I'll say to someone is this is not going to be a quick fix, because it never is, but we can get people there. I suppose if you look at prevention, really, if someone is embarking on a couch to 5K or they're starting walking, you really want to get them into good runners and make sure that they know about their flexibility, so that after, when they come in, they're doing their nice long holds and they're stretching out the calf muscles. A lot of the time we see people coming in, they've taken up a new exercise. They're walking or they're climbing hills and the muscles have got tight, their footwear is poor, and then they start to feel the heel pain coming in. So I suppose the first thing that we do when they come in is try and figure out where the pull is, what's pulling into the heel. Sometimes it's just the calf muscle, sometimes it's more than that. So if you consider where the heel is, you've got the big toe on one side and that windlass that we talked about. So the first MTP has to function, has to be able to dorsiflex. Plantar fascia has to feel okay. The heel then can be in the middle. You can have the plantar fascia pulling from one end and a tight calf and TA pulling from the other end. And then you've got your hamstrings and your fascial structures all the way up into the lumbar spine. Maybe a leg length difference, could be a lumbar spine issue as well. So I suppose the assessment is the first thing to see what is pulling into the heel, where it is. So if you're talking about specifically plantar fasciitis, so then we're really looking in at that medial insertion of the plantar fascia. So I suppose the first thing we do with them is we look at their range of dorsiflexion. I'll explain to them about that 10 degrees of dorsiflexion that they need for normal gait, and then I'll show them how to do their stretch correctly, get them into really good footwear, probably get an insole in. You may choose something with a deep heel to control the heel, or if they're very tender, you might be going with something softer for shock absorbing. So that really depends on how they're presenting. And unfortunately, they do have to pull back on exercise at that time. So once the plantar fasciitis has set in, really walking is just going to aggravate it. So we'd be advising people for swimming, cycling, getting the mat down, doing their core work, keeping up their exercise program, but not in a weight-bearing capacity. And then as quickly as possible, getting them back to their program.
Right. So offload, calm everything down, and then reload within tolerance.
Yeah, absolutely, definitely. So find out where the problem is. And I should probably say from a pelvis point of view, we are always looking for that leg length difference. So if someone comes into you and they have heel pain on the right side, you're looking at them standing, and if you see that right foot is pronated, the left foot is fairly normal, you're thinking, well, what's going on up in the pelvis? Why is that right leg not sitting the same way as the left? Okay. So you may choose to correct the pelvic asymmetry, or you may choose to leave that alone, maybe put a little heel raise in, but we have to get the foot sitting and functioning well.
Happy and healthy, because
another thing I was talking about on the course was that little test for tension in the back of the heel. So when the patient is lying on the couch and you hold in underneath their heels and you just draw the heels a little bit down towards you, and it's really nice to feel how much give is in at the back. And often you'll feel on the asymptomatic side that the heel pulls down, everything feels lovely and soft, and on the symptomatic side there's no give, nothing at all. Right. And that's telling us that there is a hold, and unless you get rid of that hold up the chain, really your heel's not going to settle down at all.
What else could be driving it, Sheenagh? I mean, apart from plantar fasciitis, are there any other potential causes of heel pain that we just need to be aware of from a differential diagnosis?
Absolutely. Yeah, so Lou, so if you look at the back of the heel, you've got your Achilles tendinopathies, you could have a Haglund's at the back, you could have a bursitis, and then underneath the heel, you could have a problem with the fat pads. Sometimes someone will come in and their whole heel is sore and a little bit red, and that can be a problem if the fat pad is starting to disintegrate a little bit and needs control and cupping. And you could have a stress fracture if someone had a fall or someone was running. You want to make sure that there isn't a stress fracture in the heel. So we do a little test where we squeeze the calcaneus, and we're hoping that there won't be any bony pain with that. There could be a rupture of the plantar fascia. Then they probably would present in on crutches with a lot of bruising. And then some nerve issues as well. So the tarsal tunnel comes out there on the inside. So you could have compression of those little nerves, medial and lateral plantars that come out there. But they would be describing a different kind of pain, maybe a pain that moves around, or a burning pain, or some pins and needles or numbness. And then medial calcaneal nerve comes down there as well. Quite often we do see people coming in with heel pain, and it's from the lumbar spine. Okay. And that's a tricky one as well. They could have no lumbar spine pain, nothing in the leg, purely heel pain. That's the only thing they're feeling. And when you examine everything, it's very definitely lumbar spine.
So it's really looking at the whole person. Sheenagh, I wonder if I could just rewind you there just a wee bit. You mentioned something called Haglund's?
Yeah. So sometimes there's a little bump on the back of the heel that can form if the foot is pronating and supinating too much, so too mobile in the shoe, and this Haglund's can form, and that can become a painful issue for people.
Okay, thank you for clarifying that. Yeah. So would it be fair to say, actually let me just ask you, what's your opinion on flip-flops? Are they the devil? Disaster.
Flip-flops, just, people come in, we get people at the end of every summer coming in saying, I've got heel pain, I have no idea why, and they've been in flip-flops all summer. Yeah. So we try and get people out of flip-flops into, even if they're hell-bent on wearing them, even one with a heel is better than the very low ones. Okay. But try and get them into a sandal or a wedge or something that has a bit of control in it. But the flip-flops are so low with no control, and the feet are working away trying to keep them on. So
they're gripping the whole time. So then I suppose the corollary to that would be, how do you feel about barefoot shoes?
Yeah, I'm not a huge fan of them.
Ooh,
I know they were not terrible.
No.
I suppose being someone who has very tight calf muscles themselves, I just could not imagine being barefoot. I'm always in something with the heels. So the idea of in a barefoot shoe for me would be a no-no. I think for people that have that lovely length down their posterior line, that their heels would just sit down on the ground and everything functions well, they probably love it. A lot of people we see are tight in the calves. I'd say 80% of people coming into me have tight calf muscles. So every single one of those, if they went into a flip-flop or one of those shoes, they would develop problems. So it's the other 20% that love them.
So it might be something a bit more aspirational, for those. But so you would never go straight from, say, wearing a heel shoe into a barefoot shoe. It would have to be a gradual progression, working on your flexibility.
Yeah.
Okay. What for you is an ideal everyday shoe? Are we talking about, runners, trainers, or, what's your general recommendation?
Yeah, generally, because again, most people are a little bit tight, I recommend something with a bit of a heel, and that could be just your standard runner, because they tend to have a nice heel. So like your Asics or your Nikes or something, they tend to have a good heel in them. We're looking for a firm heel counter. So I tell people, you go into the shops, squeeze the heel. The heel should never fold in on itself. It should be firm enough to hold your heel steady. So you're looking for a little bit of height, nice heel counter, and something with a bit of an arch in it as well. Okay. So if you think of the worst case scenario, like the Converse, the Uggs, the pumps, something that you look at them in the shoe shop and they're just flat across, there is no bump or raise in it at all. That is the worst case scenario. We're looking for something with movement in the sole, something that's just going to help you to move along.
Right. But would you recommend then when you're at home, like barefoot as much as possible, or what's your stance on that? Like when I say barefoot, I don't mean barefoot shoes, I mean actual bare feet.
Actual bare feet. And again, some people love that and they'll come in and they can't bear to wear shoes in the house. And if you're comfortable being barefoot, that's fine. If someone comes in and they have heel pain or an acquired adult flat foot, then I'm telling them no. Even if you have to have a special indoor runner or a special indoor shoe that you keep just for indoors, but for them being all day, if they're pottering around all day in the house with a foot that's really compromised, it's just not going to help their issue at all. But if someone is pain-free and they're comfortable and they're walking well, there's no problem with being barefoot in the house. So
at the end of the day, it really comes down to comfort and function. You know, I mean, if your feet are unhappy, you know, there's something wrong, and you give them what they want. Is there a role for heat or ice?
Yeah, if you're looking at plantar fasciitis, the ice is really nice on that. So especially if someone is been on their feet all day, or they're away traveling, or they're away for the weekend, and that heel pain really flares up, nice packet of frozen peas is lovely because it molds in around the heel, and they're going to sit that on for about 10 minutes and let it all cool down, and that works really, really well. Perfect. For heat, obviously not if there's inflammation, but if someone has an achy foot, then the heat will be nice on it. But we're probably talking more about ice and those acute things.
Just to calm things down a bit. Do you feel hydration has a role to play at all? You know, or nutrition? Any insight into that, or do you pass that on to your colleagues?
Well, I think a lot of people are becoming more and more aware of this now, which is great. I think for all the tendons now in the body, we know that hydration is a factor, and most of us are not hydrating. And if you think of women, as you're saying, coming in towards the perimenopause and the menopause, where the tendons are a little bit under pressure, then hydration is going to become more and more important.
Right, great. I think, you know, it's funny that we're doing this today, because yesterday was the anniversary of Leonardo da Vinci's death, and he wrote a lot about the foot as this marvel of engineering. Yes. So we have, a quarter of the bones in our body are in our feet. So if our feet aren't happy, nothing else is going to be happy.
That's right.
We know there's links between the foot and the ankle and stress incontinence, you know, so they really are, I think, so important. And I think sometimes they get left out. They can be incredibly complex. But I think you've really simplified a lot of things for us today. One final question that I just have for you, just to clarify, you gave a really useful tip on the day of the course, whereas if you're standing looking at somebody from behind and you see too many toes coming out the side, what might that be a clue could be coming down the line?
That's a clue that there is overpronation there. Okay. So what happens when the subtalar joint pronates, I won't get too technical, but when the subtalar joint pronates, it unlocks the joints distal to it. So the foot becomes mobile, and we need that for normal gait, because we need to be able to accommodate to the ground and for shock absorbing and for balance. But what happens sometimes is that there's too much pronation, or it stays too long and the foot isn't able to resupinate. So when you look at someone from the back, if the foot is pronated, the foot is unlocked, and then the mid-tarsal joint is unlocked, and that foot abducts. So you're seeing abduction in the foot. So when you look from behind, you can see their toes. You can see too many toes out to the side. So that is that nice little test. The other thing that I just wanted to mention that we talked about on the day was the idea of the foot and the core.
Yes.
So that was it's just such a lovely parallel to the core muscles in the trunk, and it came out with that study back in 2000.
Oh, McKeown study, yeah.
And it's just such a lovely idea, talking about the intrinsic muscles in the foot, and then you have the multifidus and transversus, and then you've got the long levers down in the foot, and then you've got the long levers in the trunk, and it just really makes sense to me, and I think it really makes sense to the patient. So when you're telling someone how to work their intrinsics, it's such a tiny specific movement, it frustrates a lot of people. So by telling people that these are your core muscles, and everyone knows the core muscles in the trunk, and most of them are doing Pilates, so I would tell them, you know how hard it is to learn how to draw in your transversus, your lower abdominals, and how long it took you to get used to this. This is the same thing. So it's a very subtle movement, and it takes a little bit of time to learn, but once you learn it, it's there, and you're really improving the strength in the foot. And the studies are really good on that, and they show, for example, if you have heel pain on one side and not on the other, and they look at the whole volume of intrinsic muscles, on the side with the heel pain, the intrinsic muscle volume is down. So it is a really important part of that, and I think by explaining that to people, and for us even to think of it, it helps to sell the exercise. It helps with compliance.
I think it's really interesting, so because when we look at the map of the homunculus, how our sensory relationship between the brain and the body parts, the toes and the feet and the ankle are right next to the pelvis and the genitals.
Ooh, interesting.
So, you can work on activating, the foot core and the pelvic core at the same time. But I'm wondering, is that why they call them toe curling orgasms?
Ooh.
And on that note, but if we do look at brain mapping, they're right next to each other. So I think there's something going on with that connection. Maybe McKeown was onto something with that paper. I'm going to put a link to the paper in the blog post that this video will be embedded in case people want to take a deeper dive. Sheenagh, where can people follow you? Are you on social media, or if people want to come and make an appointment with you, how can they?
You can. I'm not great on social media, but I do have a website, which is clinicalpilatesdublin.com, and I work in the core clinic, which is in Cornell's Court, and I'm available for any questions or any queries. SheenaghSexton@gmail.com.
Brilliant. Sheenagh, I can't thank you so much. This was absolutely fascinating. I just feel like knowledge bombs left and right, and lots of things for us to think about, but really simple and easily implementable strategies for good foot health, particularly at middle age. So thanks a million for joining us today, and I'll put all the links in the blog post below.
Okay, thanks, Michelle.